Good evening, friends and respected seniors. I first of all thank Dr. Sushil Chaman for inviting me to moderate this session. On behalf of Physician Forum of India, I invite the esteemed panel of consultants from Cloud9. They'll be delivering the various talks on male infertility, genetics, gynecology and pediatrics. May I have the honor to first introduce my very good friend, a gynecologist from Cloud9, Dr. Neena Singh Kumar. Dr. Neena Singh Kumar is working as a Director of Obstetrics and Gynaecology in Cloud9 Hospital. She is highly experienced in handling high-risk obstetric cases and infertility. She has authored many chapters in various books and attended many conferences. May I invite Dr.
Thank you. Thank you for your kind introduction. Thank you so much. So friends, here I'm just a very common topic as to when one will need a gynecologist. The basic idea of presenting this was that which age group and with which symptoms the patient should be referred or should be coming to a gynecologist. So if the common question would be, if I'm healthy, do I need to visit a gynecologist if it's a female? The answer would be yes, at least once a year. What exactly we do in that once a year visit, I will just go through my presentation.
Sorry, Dr. Neena, just an announcement to be made. Just 10 to 12 minutes for each speaker.
Yeah, so thank you so much.
Okay.
The adolescents, they are the main group I think we need to address to because they are young, they are complex, they are confused about their growth. They need to be addressed to. There are certain gynae problems, pregnancy-related issues, and of course, last but not the least is menopause. Now, if I'm healthy, why I need to come? This is kind of a preventive health checkup. Friends, where you all contribute to this. Women come to you with various symptoms, they come otherwise, and why they need to come is because we want to make early diagnosis of breast cancers, of female genital cancers, of anything sinister happening in their body, in which we take a detailed history, we do a pelvic examination, we do a breast examination, we do a blood profile which includes all these active health checkups such as thyroid, mammograms, their vitamin Ds, pap smear for a female, and ultrasound at the basic. And if it is a perimenopausal or a menopausal age group woman, then we also advise them with mammography and bone mineral density study. Adolescents are the most important age where these girls are attaining puberty, they are having their periods, they are having irregularities. The polycystic ovaries, once you go for an ultrasound, a physician orders, so they have ultrasound which is showing polycystic ovaries, and the mothers are so tense and they come, oh doctor, the patient has cystic ovaries, does she need surgery? So you need to allay the anxiety, and the best in adolescence is it's basically requiring just a consultation and hearing them out what are their problems. Once the mother comes with tension for some other reason, you sit with the adolescent without the mothers and you hear what all they have to ask you. They have to ask you about their menstruation, they have to ask about the development of their breast developments. They want to know whether they are gaining weight or losing weight. They are worried about polycystic ovaries, little hair growth on their face. They want to know about contraception, which they don't ask before their parents. And this is the most important, is they need counseling because of the vaping, the drugs, the drinks. So we need to see and address to this age at this moment. And last but not the least is the vaccination, in which the cervical cancer prevention vaccination becomes the foremost, and we need to educate the parents, irrespective of what they come for, about the vaccination, because that is what will make them remain healthy throughout their life. Coming to the reproductive age group and the women past 25 years of age, they have various menstrual issues or chronic pelvic pain, they are having pain in the lower abdomen. Many of them are walking in with the ultrasound report of fibroids, but that does not mean every fibroid needs surgery. Adenomyosis is just basically the uterus getting bigger and thicker and causing a lot of period issues or vaginal discharges. In the menstrual issues, when the patients are to be coming to us, is when they are having too long cycles or too short cycles, unpredictable cycles, excessive bleeding, postcoital bleeding, intermenstrual bleeding, painful periods, and the premenopausal symptoms or even menstrual symptoms. Main causes for this are the hormonal disturbances, the bleeding disorders, the fibroids, pelvic inflammatory diseases. This is where we all come in for. After the examinations, we discover there are polyps or the patient has adenomyosis. The basic diagnosis in them will come, of course, with the history and examination, but we do the blood test. We also have to exclude in chronic pelvic pain that the patient is not having ectopic and do a pregnancy test for them. A pap smear is a routine investigation, the ultrasound, and depending on the polyps or endometrial thickness, we may have to subject them to hysteroscopies, which is looking inside the uterus and helping them out with their polyps with minimally excess surgery. Coming to chronic pelvic pain, any patient who's complaining of pain, dragging feeling, when she walks, she says, I'm feeling very heavy down there. It seems as if something is stuck in the vagina. So that is the time that we want to look into something like endometriosis, painful cycles is the main course. Many of them will come with infertility, inability to conceive. The ultrasound is showing bilateral chocolate cysts or cysts in the ovaries. So we normally, in young individuals, we treat them with drugs. The surgery is not the answer for endometriosis any longer in younger age group, unless and until it is because of chronic pelvic pain. And also in infertility, many of the times we basically help them to conceive, which is again a treatment for the endometriosis, and not do laparoscopies or surgeries in them. It is a symptomatic relief for these patients with either surgery or medicines, depending on what kind of case it is. In pelvic inflammatory diseases, we normally find patients have pelvic pain, and when we examine them, the ultrasound is showing nothing other than just congestion in the pelvis, so they sometimes are treated with antibiotics. We need to find out what is the reason for this pelvic inflammation. Is it a chronic disease like tuberculosis, or it is something like a pelvic infection which is bacterial, and treat it accordingly. Fibroid is a very benign condition. As you can see, we can have multiple types of fibroids, which may be small, maybe inside the uterus, or maybe just inside out. And small asymptomatic fibroids are not needing any treatment whatsoever. They are not for hysterectomy, they are not for any surgery, nothing is to be done for them unless and until there are symptoms. The symptoms are that the patient has heavy periods, she has dysmenorrhea, she is infertile, or it is coming on the inner lining of the uterus and causing heavy cycles. So we just approach them hysteroscopically and just remove this particular part, which is an unwanted part or the unwanted fibroid, and leave them alone. In the vaginal discharges, it may be a very common symptom of just a yeast or a fungal infection or bacterial vaginosis or trichomoniasis. In menopause, it may be even neutrophic vaginitis, or it may be as sinister as cancers. So we need to take pap smears for them. Coming to the frequency of the pap smears, they normally, the age group where the pap smears should be taken is from 25 to 65. We do have cytology as well as the human papillomavirus detection. The cytology should be done at 25 years of age, or rather started from that age, and the human papillomavirus testing normally started at the age of 30, not before that. And we repeat the cytology every 3 yearly, and we repeat the human papillomavirus the detection every 5 yearly. Coming to the pregnancy related issues, the patients come to us for pre-conception counseling. This has become in vogue. Before they get married, they want to know about contraception. They do not want to have unplanned pregnancies, and that is a way forward to obviously not have any wastages in pregnancy and have valued pregnancies and small families. Antenatally, when they get pregnant, they are in our care, and postnatally, of course, we look into their vaccination and contraception again. If there are unwanted pregnancies because of failure of contraception, there are medical methods as well as surgical methods to do that. Once they have completed their duties, settled their children, they are in the menopause, they are free, and but along with that comes hot flushes, cold sweats, vaginal dryness, sleep disorders, and mood swings, for which these women come to us. We do have treatment for them in the form of ancillary treatment. Sometimes they require hormonal treatment depending on which patient requires what, and also when they come for these symptoms, it is our duty to see that we prevent them having any of these breast cancers or ovarian cancers or vaginal cancers. So what do we do in this examination? We educate them for breast self-examination. If there is any nodule or anything palpable, we do ultrasound of the breast, we request them to do mammographies, sometimes we end up with the FNACs, this fine needle aspiration cytology or excision biopsies depending on the situation. Coming to the cancer cervix, we have pap smear, human papillomavirus testing. If we find an erosion like this, we would like to know that there is no incipient cancer. We like to do colposcopy and cervical biopsies in this set of patients. Abnormal vaginal bleeding, there can be a sign of uterine cancer if the patient is postmenopausal and has bleeding. Of course, we'd like to do an ultrasound for her. If we find there is something suspicious, do a hysteroscopy, take directed biopsies. Sometimes, to my surprise, I have seen most of the postmenopausal women who are having endometrial thickness are only having polyps. They only need a polyp removal. They do not need the removal of the uterus. Coming to ovarian cancers, normally there are no symptoms. Unfortunately, they have very vague symptoms of abdominal pain and fullness, and then when we do the diagnosis, depending on the severity, whether we need to give chemo, we need to do debulking surgery or radical surgery, would help them. If you haven't seen your gynecologist for a long time, I would expect that all these patients should be coming to the clinic so that we can be of some help to them. Thank you so much.
Question answer in the end.
Thank you, Dr. Neena, for such a concise talk on gynecological problems in different age groups. Now I invite yet another good friend of mine, Dr. Bhavna Banga. Dr. Bhavna Banga is an internationally trained, dedicated fertility and IVF expert with clinical experience of over 19 years. At present, she is a clinical director. And unit head, Department of Fertility and IVF, Cloud9 Hospitals, South Delhi. Initially, she was a director and head, Department of Reproductive Medicine at IVF Max Healthcare. She has taken various trainings at various international centers. Only to mention a few: Monash IVF, Melbourne, Yale University, Yale Fertility Center at Yale University, and Weill Cornell Male Reproductive Center in New York, where only very few people go. Dr. Bhavna, all yours.
Good evening, everyone. At the outset, I would like to thank the Physician Forum of India for having us, giving this opportunity to share the space with esteemed colleagues and seniors. So I will be talking something on a very offbeat topic on to male infertility, and I would like to draw the attention of the members here that do we ever think that he matters? Did we ever think that he matters into the infertility treatment? Because we are so much fascinated and obsessed with the woman being at fault, and that is a social norm. So let's break this taboo and let's dive into a discussion that he does matter, and we need to focus on what new novel interventions are there into male infertility, and what does my talk over the next 15 minutes highlight to you. And I am sure at the end of it, you would definitely change your perspective and agree with me into my discussion that he does matter. So, advanced infertility treatments which I shall be taking care of rest on 4 pillars: a dedicated fertility specialist, a dedicated embryologist, a urologist, and a high quality embryology lab. So why are we all here talking on the male infertility? It is because around 1/3 of the patients are contributing to the infertility where the man is affected. So looking at this slide, can anyone tell me that does this man have a reproductive potential that he could father a child? Anyone in the audience?
Yes.
Does anyone feel that he can father a child just based on this? I think yes, most of us, due to lack of an adequate understanding, would just agree to this. So let us dive in further. As per the WHO, the revised guidelines are that we need the sperm counts of 16 million. I have seen reports coming from general physicians or the old school of thought that we need around 40 to 50 million minimum count to be able to call fertile. But the guidelines are that we need 16 million with a motility of 40% and the vitality and morphology. So what do these figures say? Do they just tell us that this man is perfectly healthy? I would disagree as a dedicated fertility specialist. So let me highlight that why am I saying it? So we often hear into our family, friends, colleagues, or someone very close to us that अरे हमारे घर में हम सारे reports normal है, doctors बोल रहे everything is normal, but I don't know what is the problem. So here we have a male who has a count of 40 million, which is way above the normal sperm count. Very good motility. He is married to a young female, and her investigations are normal. So do you think the problem could be in the male? Anyone? Anyone in the audience could even think about it? But I'm sure most of us, as per the social norm and the way we are being taught into the medical colleges, that most of the problem lies in the female. So now let me just take you through that how can we diagnose abnormal semen analysis. Can we just look at someone and tell that, oh, this guy is tall, healthy, he goes to the gym, he plays sports, he just could be absolutely fertile. So we need to dive into the history, the body mass index, the local examination, obviously the semen analysis and the DNA fragmentation. I shall run you through all this because this is the pillar to let us know that a normal sperm count is not necessarily a marker for testicular function to be able to father a child. I would like to bring to the audience, I would like to highlight to the audience the concept of DNA damage, which most of the recent generation is facing. All are target-oriented lifestyle, excessive use of laptops, smoking, pollutions, toxins, infection, multiple sexual partners, pregnancy at advanced ages, early detection of cancer and cancer treatments, stress, excessive alcohol consumption, obesity, nutritional deficiency. This all is having an impact on the sperm DNA. So you would like to say, ma'am, what is the problem? हमें सिर्फ एक ही sperm चाहिए. So why are you making such a big ruckus out of all this? But the answer you would know at the end of this discussion. So these all parameters are leading to sperm DNA damage. So what does this cause? Sperm DNA integrity is vital for successful fertilization, embryo development, pregnancy, and transmission of genetic material to the offspring. DNA fragmentation is the most frequent DNA anomaly present in the male gamete that has been associated in poor semen quality, low fertilization rate, impaired embryo quality, and pre-implantation development and reduced clinical outcome with assisted reproductive procedures. High levels of DNA damage promote embryo arrest and induce the activation of the apoptotic pathway. What I'm trying to draw your attention is that the things which look very superficial has got deep-grained roots. So let me talk about obesity. If you have a man who's obese with a high BMI of over 30, but if you see his semen analysis, most of us would think, "Arey, inka the sperm count normal hai." So he's not the problem. I'm sure the wife is a problem. I would like to highlight obesity is leading to all these parameters which are highlighted into the slides. It leads to increase in total temperature, it leads to epigenetic modification, inflammatory cytokines, insulin resistance, leptin resistance, and these all parameters cause DNA damage. What does DNA damage do? It causes unhealthy transmission of the genetic material at the time of fertilization. So we are coming to doctor, how do we understand and how do we get a good yield of sperm? What should we telling our patients? What should we telling our family members or friends? Because most of our families feel that if you are a doctor, we are a doctor of all these specialities. So we need lifestyle changes. We need to avoid prolonged abstinence, because prolonged abstinence of these sperms would lead to excessive DNA damage, exercise, microsurgical repairs, testicular retrievals, microsurgical sperm aspiration, hormonal therapies, and to select healthy sperms for the IVF process. So, is there any method beyond a normal semen analysis which would tell us the functionality of the sperm? And that's where we dive into a DNA fragmentation test. It is a simple sperm test with certain instruction which will help us to know that is the sperm DNA healthy or not. Because a normal semen analysis would not let us know this. So as you can see in the diagram, a sperm with a good halo, which you can which you're seeing onto the left side of your screen, versus a sperm with a no halo. So the sperm with a good halo is showing up an intact DNA.
Dr. Bhavna, 5 more minutes.
Yeah. Oxidative stress. We all know, what I would like to highlight in the last 5 minutes is a very crucial part of a varicocele repair. Most of us we are surgeons into this forum. So we have three or four options: open surgeries, laparoscopically, microsurgical, or an embolization. We at Cloud9 Kailash Colony promote a microsurgical repair which is taking care of preserving the lymphatics and the arteries and the via and the vas, and that's how we are optimizing the outcomes. As we all know that varicocele leads to DNA sperm damage, so adequate varicocele repair, as you can see into this pictorial depiction, how well we are able to see the veins, how well we can see that with a operating microscope. We have got dedicated andrologists who are specialized, because skill matters. We need to understand all urologists are not andrologists and all gynecologists are not fertility specialists. So we have this dedicated andrology program with us. The second, I would like to highlight that does azoospermia means a person can never father a child. We have got advanced testicular sperm retrieval technology known as microtessay, where, as you can see in this figure, where we can isolate tubules containing sperms, and that we can use for advanced fertilization. So this is a beautiful diagram from one of our patients where you can see a good bunch of filled tubules with sperms which can be missed on a conventional testicular aspiration. So because of shortage of time, lack of time, I would like to sum up my presentation is that the sperm which looks freely flowing inside the body, to how the embryos are forming in the lab, through the intrauterine process, through the live baby in hand, he matters, because an abnormal DNA damage or a high DFI would disrupt any of this process over here, and it could lead to genetic or the epigenetic changes in the child. So he matters. I'm sure at the end of my discussion you would agree to me. So we need to understand that how do we optimize our men, how do we guide them, how do we send them to dedicated places so we can optimize the reproductive outcome. I would like to share that we have a dedicated team of myself, andrologist Dr. Banga and Dr. Vineet Naran, and our full-time in-house embryologist Vivek Gautam, and not to forget a high-quality embryology lab, because that is the pillar of advanced male infertility treatment. Thank you so much, and do appreciate it.
Thank you, Dr. Bhavna, for highlighting the male infertility, such a vast topic in such a brief time. Thank you so much. The next two speakers will be introduced by Saidal sir.
Friends, it's my pleasure to introduce Dr. Gazala Shahnaz. She's an MBBS, DMB and maternal fetal medicine expert, consultant in fetal medicine in various private institutions before she finally landed in Cloud9 in Kailash Colony. And her areas of interest are managing high-risk pregnancies, as we see in late pregnancies, their genetics, various genetic disorders, first trimester and later on ultrasound, which are very important for detecting these problems, for anomalies and also to some extent doing invasive procedures for which she has adequate training. She is a university topper, a big hand for her, and a reputation for being a very compassionate doctor. Over to you, Dr. Shahnaz.
Thank you so much, sir, for kind introduction. And welcome all. I think most of the person here are very less aware about fetal medicine. So it's a totally new branch. So this presentation is basically to introduce what is the fetal medicine and what we are doing at fetal medicine department. So I will start with a case. So this is my patient, 34 years old, with 2 abortion, RH negative pregnancy. First pregnancy was miscarriage and it was terminated. And second was terminated at 19 weeks for suspicion of chondrodysplasia punctata. Chondrodysplasia punctata is basically a type of skeletal dysplasia with variable presentation. Okay. So the ultrasound findings were the flat facial profile, intracardiac echogenic focus, left CTEV, talus and coccygeal calcification, which give the suspicion of chondrodysplasia punctata. But unfortunately the patient was terminated, advised for termination of pregnancy without further investigation. On autopsy, the findings were confirmed, but no further genetic testing was done. Now, the patient has no significant medical, surgical, drug history, no history of alcohol exposure, nothing. No history of any pregnancy-related complication. The pregnancy came for preconceptional counseling in the 3rd time when she is planning for new pregnancy. So, obviously, we start with the basics. So, we had done the routine preconception test. These all are normal. We started on folic acid. Counseled about the various type of CDP, what is CDP, it can be genetic, it can be immune related, it can be of variable penetrations, it can be of variable inheritance. So we had evaluated her for autoimmune disease because we don't have the genetic content of the fetus, we can't go for the genetic testing. We have suspicion of immune condition right now. So we evaluated for autoimmune disease and her ANA level is very high, with high ribonucleoprotein positive. So she was diagnosed with mixed connective tissue disorder without having any symptom. Rheumatology consultation was taken preconceptually, but obviously she had no complaints, so she was not started on any medication. So she came after a few days with positive pregnancy with a happy mood that I am pregnant. 6 weeks ultrasound suggestive of live fetus. Routine ANC was normal. Indirect womb test was negative. We had referred her again to dermatologist and she was now started on SCQ, aspirin and injection Clexane to avoid the thromboprophylaxis. But for surprise, we did the ultrasound USG at 12 weeks for nuchal scan. Nuchal findings were normal. So dual marker was sent, it was also normal, high uterine RTPI because of the mixed connective tissue disorder, I think, because it is associated with the placental insufficiency, screen positive for preeclampsia FGR. But apart from that, when we do nuchal scan, we also look for the anatomical feature in all these babies. So the baby again has a flat facial profile, intracardiac echogenic focus, coccygeal calcification, and left CTEV with talus calcification. Now again, she was in problem what to do. Now we had to terminate this pregnancy again. We counsel again her that it may be genetic because it's recurring. It may be immune because you have the autoimmune condition, but we need to evaluate. So she went back, had multiple consultation here and there, and come again at 16-17 weeks. We did an early target scan. The findings were confirmed again, the flat facial profile, intracardiac echogenics. Now we can also look the femoral epiphyseal calcifications, talus calcification and coccygeal calcification. Now we counsel her again to go for the pre-test counseling. In this, there is possibility of CDP. It may be immune also. Prognosis depends what is the cause for this recurrent binder phases and chondrodysplasia like pictures. So we advise amniocentesis. Couple had no option, but she went for amniocentesis. For her relief, all the microarray whole exome sequencing, the detailed genetic evaluation was negative. So now that counseling has been changed. So counseling was now immune, it is the immune CDP. It has a good prognosis with mild neurodevelopmental delay. There is a risk of placental insufficiency, but we can manage it. We will keep you in preeclampsia surveillance and growth rate surveillance, and long-term follow-up is limited because these cases are very less in number. Only 24 cases have been reported till now. So couple opted for continuation of pregnancy, and on follow-up scans, obviously the findings are same. The midfish, we put on the growth surveillance, growth restriction developed, but the baby was delivered at 37 weeks for cerebral redistribution. The baby was alive, healthy. This was the picture of the baby at the time of birth, and the baby is now 6 months old with age with normal milestones and development. So this is my role to optimize the maternal and fetal condition in high-risk pregnancy, considering it's a medical disorder or genetic or ultrasound related. So role of fetal medicine is risk analysis to make it a high risk or low risk, to rule out birth defect, screening and prevention of common pregnancy condition, prenatal screening and diagnosis for chromosomal or genetic condition, and fetal therapy and intervention. So risk analysis, we take detailed history for all patients. All pregnancy are risk, not only the high risk, that will count for 20 to 30%. Early pregnancy screening is important, and you need to repeat each subsequent visit whenever she comes to your contact. So our role is to provide appropriate information for the test and treatment according to the patient profile. Next most important role of fetal medicine is doing ultrasound. Genetic birth defect is only 1 to 2%, but it accounts for 15 to 20% of neonatal death. Major structural abnormalities occurs only in the first trimester, and we can even diagnose it with the standard protocol as early as 12 weeks of pregnancy. There are some anomalies which manifest later, and we need to recheck it again in the growth scan. So with the standard protocols, we are using even the ISO guideline at 11 weeks and diagnosing all major abnormalities. So different type of ultrasound. So different types of ultrasound you all are introduced. That's the viability scan. It's not only to confirm the viability but to look the pregnancy complication. Whether it's the nuchal scan, we look also the anatomy and screen for preeclampsia FGR. Anomaly scan, in this also we look for everything, and growth scan to look the growth potential of the baby like a placental complication to optimize the maternal condition. Now the screening for aneuploidies, so every patient has a risk. This increases with maternal age. We need to know which patient is high risk. So we have to offer a battery of tests. There are many screening tests available. We have to tell the patient all the benefit, risk and alternative before giving them option for this test. The choice to accept or decline any test remain on the patient. So different screening tests have different detection rate with different risk and benefit. We are using base level, so with extended screening which has a detection rate of 95%, which is relatively comparable to the NIPS. NIPS is a better test with 99.9%, but obviously it cannot rule out any structural abnormality, or in the presence of structural abnormalities, we don't need to offer the cell-free DNA or NIPS. Pre-test and post-test genetic counseling is important. So there are a group of couple, after screening you will get to know that they are very high risk for chromosomal abnormality and genetic syndrome, and in these cases you need to get invasive testing, that is diagnostic, and includes chorion villus sampling depending upon gestation, amniocentesis, chordocentesis, or other. Sometimes we need to take amniotic fluid, ascitic fluid tap or pleural fluid tap to know the pathology. So now the importance of early prediction. Why we are focusing now to move from level 2 to level 1 scan? Because we get a sufficient time for genetic testing and diagnosis, opportunity to decide terminate or not. Early termination is less morbidity, mortality, reduces perinatal death due to birth defect, better understanding of physiology, and improve maternal and perinatal outcome. So this is a picture of intestinal obstruction video. So this patient come at 3rd trimester with bowel obstruction. So the patient has been diagnosed with bowel obstruction in antepartum only, and the baby was operated on the 2nd day, and the baby is doing good. So role of 3rd trimester ultrasound is also to diagnose the late onset abnormalities. So new one is the fetal therapy. Fetal therapy is not just the surgical procedure, it's also the medical treating for prevention to therapeutic for neural tube defect, congenital adrenal hyperplasia, congenital heart block, fetal arrhythmia we are managing with the medications, and in therapeutic we are treating the cardiac arrhythmia with pediatric cardiologists. We are doing the intervention like hyperthyroidism, hypothyroidism managing inside the abdomen of the baby. Fetal surgery, so there's a corrective procedures and there's a procedure which prevent further damage. It includes the intrauterine transfusion, fetoscopy, open fetal surgery, RFA, basicoamniotic shunt, thoracoamniotic shunt, and fetal endoscopic tracheal occlusion in case of congenital diaphragmatic hernia. Even now we are doing that's ended only. So now it's not only the fetus, we also need to assess the mother to screen for preeclampsia, preterm birth, prediction of cesarean scar, placental pathological complications, screening for gynecological condition. Because the mother is as much important for us, not only the fetus. The prime importance is only the mother. So screening for preeclampsia and FGF. Initially we are doing only the history-based screening and it has a detection rate of only 40%. Now we are using the combined screening in which we are taking mean arterial pressure, uterine arterial, everything, and the prediction for preeclampsia is around 90%. Because it's important, we can give the patient echosprin at early gestation and we can prevent the preeclampsia by 80%. In my patient, which I had discussed earlier, we had given the echosprin and there was no preeclampsia, even if she was very high risk. Ultimately, multiple pregnancy, obviously there is a role of fetal medicine to diagnose the type of pregnancy, whether the pregnancy related complication. If there is discordant anomaly, we need to do fetal reduction. Unique complication, managing the unique complication of pregnancy like TTS, TATF, and pregnancy complicated by single fetal demise. So take home message is not all pregnancies and babies are potentially at risk. 20 to 30% are high risk, we need to identify them. Every pregnancy needs screening at each visit. Screening to be started at first visit and to be seen in each and every visit. It is important to provide information, appropriate information, test and treatment according to individualized person. And management of pregnancy is not a single-handed person work. It is a state of art and required multidisciplinary teamwork. Thank you for patience.
Very good. Thank you, Dr. Shahnaz. Right from alpha fetoprotein, where fetal medicine started, it's gone a long way, and a lot of new things have been added to fetal. Yeah, but
not in India right now.
interventions are very little right now.
It's coming. It's now in some hospitals has been started. We are also planning to start soon. So, but intervention labor and RSC are always.
Thank you, ma'am. Now, it's my pleasure to introduce Dr. Somalika Pal. After her MBBS, she did her MD Pediatrics from Safdarjung Hospital, and then DM. She is a trained neonatologist from MAMC. She has done a DNP also. After a senior resident, she worked as assistant professor in RML in Lady Hardinge Medical College. She is also a university topper and she is a certified trainer for advanced neonatal resuscitation and faculty-based neonatal care program with the Health Ministry. She has a special interest in looking after preemies and prematures and sick neonates in the NICU. Special interest in non-invasive ventilation and nutrition, especially parenteral nutrition. Numerous publications in journals, both national and international, and articles in textbooks, and the best research paper in neonatology in 2019. Over to Dr. Somalika Pal.
Thank you, sir, for the kind introduction. It's indeed a privilege to be in the presence of such august audience. So my topic for today's talk is optimizing care of the preterm neonate in the delivery room and the NICU. So before I proceed, I would like to stress why I chose this topic. So like you all know, around globally, about 15 million preterm babies are born every year, out of which 1/5, that is around 3 million preterm babies are born in India alone. So So we bear around 1/5 of the burden of prematurity of the world. This amounts to around 10 to 15% of babies out of all birth. So they are all born too soon. But the preterm is a very heterogeneous term. So prematurity ranges from the periviable period 23-24 weeks to up till 36 plus 6 weeks, where the outcomes we all know are much more optimum. So it's a heterogeneous phenotype, and the outcomes in preterm would depend not only on the gestation and the weight, which are the major determinants, but also on the cause of prematurity. So delivery room and NICU protocols may vary based on what kind of setup we are working in, what is the logistic, feasibility, manpower, infrastructural abilities, what kind of setups we have. So admission criteria, discharge criteria would vary on a lot of factors. So I'll first come to antenatal interventions that we can do to optimize premature outcomes, delivery room interventions, and finally the NICU outcomes, NICU interventions. So antenatal interventions, the most important thing we can do is transport a imminent preterm delivery intrauterine. So like we all know, once we transport babies, once they are born, after they are born, especially premature babies less than 30 weeks, prematurity has been cited in studies as one of the major indications for neonatal transport, and it is a significant predictor of neonatal mortality when babies are transported at less than 30 weeks gestation. Mortality is significantly higher among transported neonates, and up to 50% of transported neonates die within 24 hours of transport. The causes could be many, ranging from hypothermia, cardiovascular problems, respiratory issues, transport-related problems, and the like. So adequate pre-referral stabilization and dedicated transport teams improve outcomes. So communication is the key between the referring hospital and the hospital which is about to receive the baby. So like I said, intrauterine transport is the safest. So if you come to the baby, the mother is about to deliver imminently and there is no immediate risk to the life of the mother, then consider transport to a facility with a tertiary care level NICU service. So tertiary care level NICU facility is one where neonatal ventilation, including advanced care ventilation, can be provided. So CPAP support, up to CPAP support is a level 2 NICU, more or less. Before transport, we should ensure antenatal steroids if the delivery gestation is less than 34 weeks. And in case the patient is about to deliver at less than 32 weeks, magnesium sulfate has been shown to offer neuroprotection. Cerebral palsy and gross motor dysfunction can be reduced by an RR of 0.68 in case of antenatal maxillofacial given at less than 32 weeks. RCOG says that we may even offer 32 to 34 weeks gestation as well. Now next we come to delivery room interventions. So like we say for neonates, we always speak in terms of TABC, temperature, airway, breathing and circulation. So I will start with delivery room temperature. So ideally when a preterm baby is about to deliver, the temperature should be around 26 degrees and it is very important to maintain a warm chain, meaning that the delivery room temperature, receiving baby in a pre-warm linen, immediate skin-to-skin contact as and when possible. In case of extreme preterm births around less than 32 weeks at very preterm, polythene bag or wraps have been shown to significantly reduce hypothermia. Hypothermia in the delivery room and up to transport to NICU is again a significant predictor of neonatal mortality in the hospital and NICU. Warming mattresses like an embrace nest can be used, and it is important when we are using these additional modalities for warming that baby does not become hyperthermic. Hyperthermia also is a significant contributor to mortality. So this is a neo-HEL. The baby can be wrapped with or without head covering, and all interventions including resuscitation can be done to the baby inside this polythene bag without drying the baby. Next is delivery room interventions, immediate skin-to-skin contact in the delivery room for all stable preterm babies. So if baby has tried at birth and we have been able to give delayed cord clamping, and we can immediately put the baby on the mother's abdomen, and routine care among babies more than 32 weeks, that is as per NRP India, can be taken care of on the mother's abdomen with a direct skin-to-skin contact which takes care of the temperature. So we are practicing this at Cloud9 for all deliveries including cesarean births. Next we come to immediate KMC. So this is a very novel publication, and fortunately this is a WHO initiative, immediate KMC at birth, wherein all babies who are born at more than 1 kg to up till 1.8 kg was started on KMC as soon as possible after birth. Usually after stabilization more than 3 days, it's the norm to start KMC, but this is a recent publication in an EJM, and fortunately Safdarjung Hospital was one of the key centers, key places where this trial was conducted, and the trial was prematurely stopped because it was seen that IKMC saves babies' lives. So there was a significant reduction in mortality with immediate KMC, provided baby is stable, and this is one of the key interventions for preterm stabilization provided infrastructure permits. Next we come to delayed cord clamping, which should be practiced among all babies who are stable and cried at birth, and milking should not be done for extreme preterms because it's a risk of intraventricular hemorrhage. Again, delivery room interventions like equipments are very, very important. There should be provision of blender because hyperoxia, high target SpO2s are detrimental, can lead to free radical damage. So provision of a blender so that targeted FiO2s can be given, starting resuscitation at around 30-40% FiO2 and going up based on target SpO2s as per American Academy guidelines. Delivery room CPAP helps us causing early lung recruitment. So even if one or two breaths are given without a CPAP, without extending pressure, preterm babies who are surfactant deficient can end up having hyaline membrane disease, RDS, and later BPD. So delivery room CPAP is one of the key and novel interventions which needs to be started immediately in the labor room, and we should not delay starting of distending pressure. So NeoPuff is one of the common equipments that is used to deliver delivery room CPAP. Regulated PIP is very important, especially in extreme preterms to prevent intraventricular hemorrhage. So once we are giving bag and mask, the conventional, we don't know how much pressure we are giving, so it can lead to IVH. Next is maintaining temperature during transport using a thermal mattress or a transport incubator based on what the distance is between the delivery room and the neonatal ICU. Provision of PWP and PIP during transport, again using a NeoPuff, and pulse oximetry provision during transport so the baby is not hyperoxic or hypoxic during transport. Next we come to interventions in the ICU, again starting with temperature. So preferably if it's an extreme preterm baby less than 1 kg, a double-walled incubator is one of the key interventions which helps in survival because it protects the skin. Babies need humidity up to 80% in the first week of their life, gradually coming down as the babies become older and the skin matures. So extreme preterms need high humidity, and if they are being cared for in the open care system, we will come to the interventions that can be done. Skin care is very essential because skin is one of the main barriers for protection of prevention against infection. So humidity is one intervention. Minimizing pricks, if we have to establish lines, we should do it at the earliest. Minimize the use of adhesives. If at all adhesives are used, hydrocolloid like tegaderms or duoderms should be used. And clustering of investigations, so we should plan beforehand, not just keep pricking the baby as and when we remember. Next is respiratory stabilization. So for respiratory stabilization, I cannot stress enough the importance of delivery room CPAP. So starting with distending pressure right at birth and following it up with early rescue surfactant in the NICU as early as less than 2 hours. So early rescue is for less than 2 hours, the earlier the better. This can be given by Ensure. Recently there have been studies which show that even a lesser invasive surfactant wherein intubation is not required. So we can use a Lisa catheter to deliver surfactant as well. This ensures something called an open lung strategy, wherein we follow this up with non-invasive ventilation and high PWPs to keep the lung open, ensure better lung recruitment. Non-invasive ventilation, non-invasive ventilation like CPAP, NIPPV is preferred over invasive ventilations, and early extubation as soon as possible, and there should be provision for advanced respiratory support. Next, one of the key pillars of intervention is minimizing IV fluids. Babies should be started on early total enteral feeding. So there are studies which show that babies above 1 kg should be started on full total feeds, no IV fluids, and we are practicing with babies less than 1 kg, like 750 grams and above. They can be started on early total enteral feeding. The focus should be on exclusive human milk feeding, preferably mother's own milk feeding, for which a dedicated lactation support team is essential, wherein expression is started as early as possible. For babies who we are not able to start on early total enteral feeding, we can start on with colostrum mouth painting, helps in better colonization of the gut with mothers with good bacteria. Fortification protocols should be in place. Early initiation of KMC, as I have already shared. So these are babies getting KMC on respiratory support, twin KMCs and KMC during COVID as well, because KMC saves lives. Next is prevention of infection, like I said, enteral feeding, rapid escalation of feeds, using MOM feeding, having care bundles as protocols like CLAMSY prevention bundles and VAP bundles, parenteral nutrition preparation checklists and using laminar flow wherever possible, daily assessment of need of lines. So if a baby has a line, we should ask ourselves is it needed and remove the lines and the IV cannulas as soon as possible, and assessment for extubation readiness. So these are the bundles we are using at Cloud9 as soon as baby has any kind of line or is intubated. Next we come to antibiotic stewardship, so minimizing use of antibiotics, judicious use and early stoppage as soon as possible, and PD preventive strategies like gentle ventilation, starting off caffeine, restricting fluids, postnatal steroids as required, minimizing infection. Facility for point of care ultrasounds, echocardiography, early PDA screening to determine the choice of inotrope and when and how we need to escalate, minimizing sampling, intraventricular hemorrhage prevention strategies and screening with use of point of care ultrasound, and developmentally supportive care, babies kept well nested, quiet times, clustering of sample, pain, prevention of pain and management of pain. There should be pre-discharge protocols in place. So before a baby is discharged, so RBSK, retinopathy of prematurity is one of the key areas wherein the government is now focusing with the Mission NEEV and the NEEV program, and it's a very, very big medical legal issue. So all babies who are born at less than 34 weeks or less than 2 kg should definitely undergo an ROP screen when they are eligible, which is roughly around close to 31 weeks or at least 3 to 4 weeks post-menstrual age. The younger, they may even need earlier at 2 weeks. So ROP screening before discharge, hearing evaluation before discharge. For preterm babies, we should get an automated AVR. Anemia of prematurity screen, metabolic bone disease screen as and when babies are eligible. Detailed neurological evaluation using a Hammersmith neonatal neurological examination tool, which is an objective tool, 36 to 40 weeks gestation and followed thereafter as the baby comes on follow-up. Pre-discharge nutrition with either HMF or multi-component supplementation, or if baby is on mother's milk, we can change to multi-component supplementation. Preterm immunizations are very important. For extreme preterms, the option of giving pavlizumab is also very, very important, the RSV prophylaxis. Next we come to after discharge, there should be a facility for high-risk follow-up. Last slide, sir. There should be facility for a high-risk follow-up once babies have been discharged from the hospital, especially preterm babies. So multidisciplinary team which requires a neonatologist, developmental pediatrician, may require an ophthalmologist, speech pediatrician, ENT person, lactation support, child psychologist. So it's a whole battery, so there should be either under one roof or at least referral services should be available. And a structured follow-up performer which includes anthropometry, neurological examination, including behavioral assessments, because ADHDs, cerebral palsies, behavioral disorders, autism are very common in these new graduates. So the take-home message is that the focus should be not just on preterm survival, but on intact survival with optimal long-term neurodevelopmental and respiratory outcomes. So BPD, ROP, all these adversely affect the baby's neurocognitive outcomes as well and cause significant hospitalizations, morbidity, sick days, loss of school days. So we have to focus not just on the survival and discharge from NICU. Exclusive human milk feeding, minimal pricks and handling, early KMC, judicious use of antibiotics, judicious investigations, minimizing blood product transfusion, including restrictive thresholds for transfusion, early lung recruitment strategies, gentle non-invasive ventilation, and good hand hygiene are the cornerstones of good optimal outcomes in preterm babies. Thank you everyone.
Thank you, Dr. Somalika, for an exhaustive, elaborate.
We'll start with the first two sessions. Dr. Gurmeet Bansal, ma'am, please take over and conduct the question answer session for the first 2 hours. Take a seat, Dr. Neena Singh, Kumar, ma'am.
Wonderful talk by all the speakers. May we have the questions from the audience, please?
Dr. Abha, ma'am, your classmate from Patiala. No, Patiala. Are you not from Patiala? No. Are you from Patiala?
I am from Patiala. I am MD from Patiala. I am MBBS with her from Amritsar.
ये तो पता ही नहीं था. Any question?
Very important to answer.
Any question?
Oh, it is such a pleasure to hear her talk.
Just a pleasure?
Oh yes.
Yeah, so आप friendship पूरी निभाई. No question answer. Ma'am, gynecologist Dr. Shirin ma'am. When to refer a case to a gynecologist? That was the topic. Yes ma'am.
अभी दिमाग में पीडियाट्रिक घूम रही है.
Well, go ahead.
दिल की गिरे खोल दो, चुप न बैठो कोई गीत गाओ. महफिल में अब कौन है अजनबी, तुम मेरे साथ गाओ, दिल की गिरे खोल दो.
नहीं खोलेंगे.
Very precise and conclusive lecture you have given now. I'm myself a gynecologist, but I want a question regarding if some GP is attending a female patient, what are the alarming signs or signifying signs that of cervical cancer, so that they can refer it to gynecologist?
I think, as I said, that the post-vaginal discharge may be the only thing which the patient will be saying, depending on the age.
Bye, Vijay.
Normally in a young patient we can think of many things, but in case it is a perimenopausal age group patient or a postmenopausal age group patient and suddenly she is having a kind of discharge which is a little smelly or having some problem like a foul smelling discharge. So we are thinking of biometra, we are thinking of other things. So I think that a pap smear is the only safeguard for this. The human papilloma virus vaccine is the only safeguard for this. That is why I am saying that the prevention is better than treatment. So it is better to catch the children young from 9 to 26, vaccinate them. After 25, get them into the routine screening, at least in private we can afford it. In rural, of course, the government is making its efforts to do that. And in the vaccination with the cost-effective vaccines now from Serum India or others available, I think it will be a mass vaccination which should be like a polio-free program, and I wish and I looking forward to a cancer-free cervix, cervical cancer-free.
Actually, there's a difference. There's a difference in the presentation of cervical cancer in the urban and the rural places. In the urban, because of the Google, they are very much aware of the cervical cancer vaccines and the routine pap smear testing. In the rural areas, most of the cancer cervical patients are brought by the relatives that she is smelling a lot. That makes the diagnosis very common. Yes. And of course, with the other symptoms of postcoital bleeding, persistent discharge and pain.
Where's the mic? Dr. Lalit has a question. Can you believe it?
Well, Dr. Neena is my chief Sali, so I am glad to ask the question. Slightly off track, not with today's topic, but a few years back there was a lot of talk about hormonal replacement therapy in post-menopausal women. What is the status now, or would you like to take a lecture separately for this hormonal replacement therapy?
Ma'am, take the mic please. विजय और माइक नहीं है, दो ही माइक है. पैसे ज्यादा ले लेगा.
If I understood the question correctly, you said postmenopausal bleeding.
No, hormonal replacement therapy.
It's a big chapter by itself as to whom and why and where we need to give next CM. We're looking forward to that. Thank you for giving me the basis for the next CM.
Dr. SP Singh sir has a question.
Thank you, sir. So I have a very simple question. A pair married, and after 2 years, 1 year, 2 years, wife never conceived. So they have been reached to the doctors, gynecologist, like this pair. And every test, investigation done, never find, nothing is not abnormal. Why they have not conceived?
See,
मेरे सामने क्वेश्चन पूरा है मेरा कैसे टू पार्ट में ए बी मैं एक की बात कर रहा हूँ अभी है so then they have asked from the doctors what is the problem why we have not conceived मेरे से मैं my wife will conceive उन्होंने कहा कोई बात नहीं हम फिर से जीन की बात करते हैं हम आपके पेरेंट्स से बात करेंगे उनके दोनों को पेरेंट्स को बुलाया और उनसे बात की क्योंकि दोनों पेरेंट्स तो अच्छे थे ठीक ठाक थे दोनों ने एक बेटा पैदा किया एक बेटी पैदा की ठीक ठाक हो गए सो माय क्वेश्चन इज व्हाट द प्रॉब्लम इन दिस पेयर व्हाई शी हैज नॉट कंसीव्ड ए पार्ट
Again, as within lecture.
next year this is yes ma'am please
see there may be a set of
every family is normal even then
in everything we also can understand what everything would actually mean, whether we have done biopsies. If you say then I understand that everything is normal, these are tubes are normal, she doesn't have endometrial tuberculosis, the husband semen is normal, even my Dr. Bhavna has explained that DNA fragmentation and the others, that is also normal. If the patient not conceived and she comes in unexplained infertility, that's by itself another issue. Their fertility workups and IUIs for unexplained infertilities may be the answer. And leading there by the age, we are running around with the age and with the age of the patient, and of course we are looking into IVF. But unexplained infertility is a topic by itself. And the treatment is, of course, if they are not conceiving on their own, then it is understood that they need assistance from us. So the first assistance would be an IUI, which is cost effective. IUI would be an intrauterine insemination, and the second.
So that I want to do, everything is done.
Yeah.
Your part is also done. Everything is fine, no problem.
Yeah, I agree with you. After that, then we come in unexplained infertility. That now we have to advance in the system to conceive. We just can't just sympathize with them and say, okay, if you're not conceiving, it's fine. Someday it will happen. It will not happen someday. We have to assist them thereafter with an IUI or with an IVF. We will have to do something in our part.
My second part.
Second question.
My second part, B. Husband and wife, they are all married, but they don't like each other. They have never come.
Go to Pakistan.
They never come. So how they can proceed the
But you also said that there was
जब आप पास ही आए तो कैसे मदद में चल रहा होगा?
बस आपने
तो आप सोच कैसे रहे थे सर? सोच कैसे रहे थे?
जवाब आपने दे दिया। Okay. Right. Friends, just a minute. We have Dr. Ratna Saxena ma'am. She is wife of Dr. R.K. Saxena sir, who is an eminent urologist and a very famous kidney transplant surgeon. And to put this in perspective, he is the eldest brother of Dr. Gynaecologist Saxena, our darling. Dr. Ratna Saxena ma'am has a question.
No question, just to support her. The reason I am speaking now is that often the general physicians, cardiologists, or the general physicians receive female patients who have symptoms of uneasiness, night sweats, bone pains, body pains, mood swings, which are often not amenable to treatments. That is when you must refer them to a gynecologist, because she will look into the menopausal part if they are above 45. So today I just wanted to tell, because all of us look after the adolescents, the younger women, we must look also towards the women who are above 45. The menopausal symptoms are many and often unrecognized by most of us.
So that makes the next CME. Thank you very much.
Any other questions? So we come. Yeah, Dr. MPS Gandhi, how can we forget you, sir? You are felicitated today.
Dr. Neena, nowadays we are having two types of vaccine, cervix and one is cardinal. Which one is better and why? The cervix is just a bivalent vaccine. It is only having 2 strains of human papillomavirus, which is basically being only targeted to the cervical cancer thing. The Gazala 4 now is a quadruvalent vaccine, which is having 4 strains of human papillomavirus. It covers not only the human papilloma, the cervical cancer, but also the genital warts. Now comes the next generation. For the past 1 year, it is available as Gazala 9, which is a nanovalent vaccine, which is covering 9 strains of human papilloma virus, because this virus seems to be also responsible for oral cancers, for anal cancers, for vulval, vaginal, and cervical cancers. So now this has become and a penile cancer. So this has become a vaccine for 9 to 26 as a vaccine of choice. As Gazala 9 is nanovalent vaccine as of today. It is available for the past 1 year. And there are 3 doses which are to be given for Gazala 9 That is day 1, 2 months and 6 months. 0 to 6. 0 to 6. All the age groups. In all the age groups. In all the age groups below 15, now the Indian Academy of Pediatrics has suggested to give 2 doses of the vaccine 0 and 6. Am I right, Somalika?
Yes. My question, actually, Mr. Dr. So my question is to the doctor who presented a talk on male infertility. I don't know. Ma'am, just wanted to know, there are many young men who come, who go to the gym and take gym proteins, and often we see them, they present with azoospermia. So, do you think this protein, male protein, is to be blamed for this problem of azoospermia?
I would not label the protein content, but they are somewhere taking testosterone supplements. So it's not the protein. So they usually take the supplements, and you can make up from the build. So we have to look into those minor histories as well. And they are not supposed to take testosterone shots for low testosterone levels. And we need to address that these days, due to target-oriented lifestyle, lot of access to Google, the patients are doing the blood test of serum testosterone, everything on their own. Moment they find the testosterone level less than the reference range, they are taking the shots and they are getting, the sexual pleasures, and also they are happy. But it is indirectly affecting the fertility.
Again, the testosterone level has to be either total or free. Which one do you prefer?
No, but so actually what is very accessible is a total fasting testosterone. Now, when you go to free and also that requires a lot of minute understanding with an endocrinologist. So we usually advise a total fasting testosterone. It should be in the range of around 500. When the levels are that adequate, and then we need to correlate with the patient's symptoms. A lot of patients are also having a psychogenic element, because again I'm stressing, huge amount of marital disharmony exists, and that we understand when we do vaginal ultrasounds for the women. When we ask them that how's your sexual life, they are like, it's fine ma'am, it's always good. There's an initial hesitancy. The moment we start doing the ultrasound, we can gauge the vaginal introitus tightening. So that the sexual activity is very dismal. Then they come out with the hidden things that my husband is lot into pornography, he's lot into marijuana, excessive smoking. I mean, it is very, very distressing. So the male infertility and the men don't want to come out with these problems. And what I would like to draw the attention of the house is that if someone is having 0 sperm counts, please refer them to a fertility clinic who has an in-house embryology lab. We see general physicians and urologists who are doing the testicular aspiration into the local setting without an IVF lab. So they are saying it is no sperms or sperms are visible. But that does not guarantee that when we redo the biopsy for an advanced procedure, we will get the sperms. One. Second is that if a testicular biopsy is showing 0 sperm, like a TISA or a TESE, that does not mean the patient cannot get pregnant biologically. We have got advanced microsurgical aspirations with the help of a microscope, where we are able to isolate islands of pockets of tubules containing sperms. These are called micro-TESE procedures. That's what was the highlight of my presentation. Scale matters, who's doing matters, where is it done matters, how it is interpreted matters. And please understand, fertility can break families, it can break emotionally the couple. So do not give any loose comments. If one is not an expert, please send them to an expert to kind of, clear all the doubts.
A small question and almost a comment. Question I got in MRCP 1 was, a man, full age of his, everything was good. Women, full age of it was fine. In the end it was written, they got a small house, their mother-in-law stays with them. UK has small house. So sometimes what you said, that the conditions cannot be versatile. It's not necessarily everything is bad. No, so the answer was send them on a holiday.
Yeah.
Dr. Vimal, our worthy pediatrician and better half of our worthy gynecologist, Dr. Shireen ma'am.
हम तुम न हम तुम नहीं अब कुछ और
Go ahead.
It's just a curiosity question. Like heart is not functioning, do heart transplant. If knee is not functioning, do knee transplant. One valve transplant, like that. If testis is not functioning, ever tried testicular transplant? And what will be the genetics of the child and phenotype of the child when testicular transplant is being done?
Answer because I don't know whether anyone of you is doing a testicular. So basically, where we are having azoospermia, which is a non-obstructive azoospermia, where the sperms are not found. So the only way one can go forward is to doing a microtessing. So this is again a very detailed, skilled procedure with the right kind of people addressing that can the patient with a non-obstructive azoospermia is eligible to undergo such an invasive procedure. So microtessing is a procedure where under 10x to 15x magnification the testes is split into two halves and it is done by an andrologist who's a reconstructive andrologist. It takes from 1 to 4 hours to find the sperms. We need a dedicated embryology lab which is very high quality, a very skilled embryologist to find the sperm from the test, from the tubules, the fertility specialist to pick up the right team to work with it because it requires passion, dedication, that junoon that leads to something for this patient. Not an alternative, we just take a donor sperm and just
Is that for IVF?
Yeah, it's done at Cloud9 and I'm no, that is not done, but we can do this for these patients.
Surrogacy, then IUI.
Yeah, but surrogacy.
These are all are being done.
Yeah, surrogacy, donor embryo programs, they all are done.
But transplant has not been tried anywhere in the world.
It's not tried anywhere at all.
Madam, I know of one patient who was diagnosed with Sertoli cells only syndrome. That was 15-20 years back. And after that, he adopted a child.
Yeah.
So what is the position now?
See, Sertoli cell syndrome is a very challenging aspect of male infertility. Even if we do a microtesting, there are only 10 to 15% chance of a sperm retrieval. So we need to ask the patients, we need to counsel the patients on that. And prior to that, we do a Y chromosome microdeletion assay. It is just a simple blood test to understand if that gene is detected, that it is deleted, and that has certain subsection. So if it got an A and B segment deleted, most of the biopsies are Sertoli cell, and there's a very poor prognosis to sperm retrieval. So we do not subject the patients to such invasive procedures when we have these tests. So that is to get the house is that we should know in whom what to do and in whom what not to do.
Ma'am presented a beautiful, I would say, viewpoint on male infertility. And ma'am, if I understand the context, you said he matters as much or maybe more than she matters. Ma'am, I want to know in what percentage of cases of male infertility he matters in your experience?
It is as high as 30 to 35%. Men do not come out. We have seen men who are 40, 45, the woman is aging, but they are more concerned that my count is just 30 million. Doctor Sahab, hame 50 million chahiye. So he will waste the time to make his count 50 million where his wife is aging. So this male fertility has to be assessed, taking into consideration the woman's age. A human sperm cannot correct the DNA which is damaged, but an egg can correct. So if you have a younger spouse, during the process of fertilization, that DNA damage can be corrected. So we need to highlight these things to the patients, but unfortunately the patriarchy is too much in our country. I think it's across the world. As per my experience worldwide, it is very difficult to break the taboo. It is very difficult to break the social mindset. So it's time to reach out to these patients. Because of taboo, they are not talking. Women ki problem hogi, so they will go doctor to doctor with the mother-in-law. But if men has a problem, they have time left. Oh, we don't have time. हो जाएगा, let's do it later on. उसमें क्या हो गया? We can adopt. So because people are not aware, there's lots of technology, there's lots of hope into male infertility. The only problem is that it's not addressed. People think that IVF से तो baby हो ही जाएगा. It is not that way. We need to have the right sperm selection, and that requires a lot of subject-specific knowledge. That is what is the house addressing. As a clinician, I am addressing. All IVF specialists may not be specialists into male infertility programs. All urologists may not be into andrology, reconstructive surgery, what I have told. Everyone will not have a operating microscope. It's around 20 to 25 lakh rupees. So all units will not invest into such programs, which we are having at our facility. So just to get that on the board.
Ma'am, as I understand in male infertility, the bottom line is the sperm count, as I understood from the talk. Now, I want to ask you, ma'am, what is the ideal way of doing the sperm count? There are many doctors who take the sperm in their clinics and send it to the lab after 4 hours because the collection time is after 4 hours. So what is the ideal way of collecting sperm?
So the ideal way, now we have so many fertility clinics, it has to be in the hospital premises with an adequate abstinence in the most sterile condition and with all instructions given that how the sample has to be collected into a sterile pot. We are not supposed to getting samples at home, and suppose if at all patient wants to do that, they are not comfortable, we do not deny that, but we give them adequate instructions that how are they supposed to take care during the transportation as well as when the sperm is collected at home.
Ma'am, what is the ideal abstinence time?
It's around 2 to 5 days.
2 to 5 days. Even 2 is fine, ma'am.
Yeah, even 2 is fine. Absolutely.
Even 2 is fine.
Yes, yes. And people say that during the fertile period, the couple usually says that we need to have sexual activity every day from day 10 to day 18. So I tell my patient that it is criminal for a man to do that. It's not possible. So every 48 hours of sexual activity would be fine. It's not required every day. But these are little things because, the things are not discussed. There's a lot of Google access, a lot of taboo. And lack of knowledge because we कोई बात करना ही नहीं चाहता है ना. If we have a son-in-law and daughter-in-law, will we get this topic that how's your sexual life? No, we will not. वो तो भगवान दे ही देगा. Don't worry, we will do this part, puja. It doesn't work. Please reach out. Please be open with your family members, your children, your colleagues. It's time to reach out and don't make the woman a mockery into all this.
Ma'am, what's your consultation with Cloud9 if I send something? I want to just
complimentary for you.
No, not for me. I'm beyond that age. I'm serious with this, ma'am. Yes. What is your consultation? What's your consultation? What is the package for male infertility in your setup? What is the individualized package of male infertility, the maximum package in your setup? मैं मरीज को कितना बोल के भेजूं? भाई देखो इतना लाख लगेगा, डॉक्टर भावना बांगा के पास जाओ, इतना लाख में तुम्हारा मालूम चल जाएगा, दूध का दूध और स्पर्म का स्पर्म हो जाएगा. बताइए मैं, प्लीज. I'm serious.
We have to send patients.
We have to send patients.
If we go for a any simple semen analysis would be from 1500 to the most advanced microsurgical procedure, it would be 1 lakh. So there is no comprehensive.
No. Forget about comprehensive. भैया 1 लाख अपने पास तैयार रखो, डॉक्टर भावना बांगा के पास जाओ, वो तुम्हें बता देंगी कि भैया तुम्हें कोई प्रॉब्लम है कि नहीं है. 1 लाख लगेगा. No, let's be blunt, man. No, इसमें शर्माने की बात नहीं है मैम. मैंने कहा ना, मैं डॉक्टर तुलसी will have 2 minutes and Dr. Kalra will have 2 minutes.
Just 2 minutes, sir. Just 2 minutes. Anyway, let me proceed and extend Dr. Chauhan's question. Dr. Banga. So, male infertility. See, varicocele account for about 40% of the infertility in males, and would you say 1/3 male, 1/3 female, and rest probably not known would cause infertility? Would you say that? Okay, talk us through the ICSI versus the IVF. See, the ICSI is a variation of the IVF. Tell us about this.
So the difference between an ICSI is, usually it is used for male subfertility. If the count and the motility and the morphology is altered, which makes the sperm incapable of a natural fertilization, then we take each sperm and we inject into the egg under an amplified magnification, which is done in a high quality embryology lab with a certified clinical embryologist. IVF is again a form of fertilization where the sperm counts are normal and we are doing an IVF for tubal infertility or an unexplained infertility. So both are forms of IVF only, but the terminologies are like IVF is used for both things.
So would you say the ICSI has dramatically changed the treatment available even for the most severe male factor infertility now because of the technique? 90% of all males have the potential to probably have their own genetic child.
Yes, they
So
do.
90%.
So even if a man has got occasional motile sperms,
Yeah.
he could still father a biological child. We have n number of success stories with us because during a journey as a dedicated fertility specialist, I have not delivered any child in the last 15 years because I somehow felt that we have got a lot of very experienced clinicians with us, gynecologists who are very good at it. But people want doctors who are passionate. They want them to be heard. They don't want them to be told that you will get a donor option. They don't want it to be just like a number game. Because even with a very suboptimal sperm count, it takes a lot of effort. How do we optimize the suboptimal sperm count with antioxidants? How skilled is my embryologist? How much time is he taking to pick up a sperm which is not vacuolated? There is a lot of knowledge required. It is not superficial. We need only one sperm for ICSI. ये तो बच्चा हो ही जाएगा.
Let us proceed with Dr. Neena. So ma'am, that was a wonderful talk by you. So just few questions, regarding fibroids. So 80% of women probably have fibroids before the age of 50, and the majority of the fibroids may disappear after the age of 50, and majority of the fibroids may be asymptomatic, but fibroids in pregnancy, can they cause some complications? Tell us, the fibroids in pregnancy, can they cause miscarriages, can they cause some preterm labor, can they cause some preterm rupture of the membranes, or you need to probably do a CS, if there are complications of large fibroids in pregnancy. Talk us through the fibroids in pregnancy.
So coming to fibroid, it all depends on the position and the size. If they are small, 2 centimeters, normally we do find about a centimeter fibroid in the uterus in the first trimester. They are also like small babies, so they also grow when the pregnancy is growing. So by the end of the pregnancy, it may be about 5 centimeters, and the patient is actually worried not more about the pregnancy but about the growing fibroid, and we just need to reassure her that this is just because of this exceptional hormonal spike that the fibroids are also, being looked after. And once she delivers, when they shrink back to their normal size, they remain asymptomatic again and they require no treatment. There is a choice. There are certain type of fibroids which do affect in the course of pregnancy. They overgrow their size, cause lot of pain, which is quite a pain for the patient because they are not in labor and they have repeated admissions. If they are very big fibroids, they can also lead to.
Okay. The most common organisms seems to be the chlamydial trachomatis infection, cervicitis to salpingitis to florid PID. So, and the risk of ectopic pregnancy also increases by 4-fold if you have a chlamydial infection. So, a vaccine probably is underway for chlamydial infections, which will probably reduce not only the incidence of ectopic pregnancies, but also probably the PID. Talk us through the PID.
Coming to pelvic inflammatory disease, for me, yes, chlamydia is an important cause, but in India the tuberculosis is too. So that is the main cause which also is detectable and though debatable as to what is the modality for that. But once we put in a laparoscope and we see that the tubes are damaged and the endometrium lining is being sent for Gene Expert Plus nowadays, so we do give them treatment and they do conceive. Many of them, they have a tubal damage which is beyond repair, so that is where the IVF specialists come in, where we have to bypass the tubes, but many of the time they are able to open up the tube, treat their infections and they conceive naturally as well.
Thank you, ma'am.
Over to Dr. M.L. Kalra sir, M for Master, L for Learned.
My last question to you, because I'm the last dabba of the train, about the self-breast examination. I had a fight with one of the legendary top person who said that he was against it. So I'm in for it. I won't want to name. What is the best time of the menstrual cycle to have self-breast examination?
That would be post-menstrual, because many times the patients have premenstrual syndrome and they have breast
Any day
breast
after that? Any day
after the periods are over, say 5th or the 6th day when she's comfortable with her breast, because sometimes these miscarriages they do persist during periods or prior to periods.
Dr. Bhavna? Yeah. So I remember the day when you joined Max, and I'm delighted to see you again here, and I'm also at Cloud9 with you now. Just my question is about the analysis of sperm what we do in your lab or any good lab. Do they give any hint about DNA damage also?
I mean, we have to ask for a special test.
So with motility, is it related to some extent?
Yes. If the motility is less, there's a higher chance of that sperm having a DNA damage. So that's the indirect correlation.
It may be. So there was a slide showing a wide prolonged abstinence.
Yes. So what it is said, that if you have a prolonged abstinence, so the spermatozoa which are there at the epididymis, there's a lot of generation of ROS, the reactive oxidative species, and that is leading to the DNA damage. So we should do frequent ejaculations.
Actually, this is also good for health of the prostate.
Yes.
Prostate health is also related to that. To make the forum live, I came across in interesting news some 20 years back. There is a village in Madhya Pradesh where twins, triplets, quadruplets, there are too many. So it is the world record holder. Almost every house has a twin, if not triplet. Even those who come and rent that place, they also have a tendency to have twins or triplets. So is there any environmental factor on the same line for the preterms also? Is any environmental factor promoting preterm levels, like they have twins and triplets? So food for thought.
I think honestly friends, now we are at 10:50 and we need to wind it up. So we had a wonderful session with 4 of our wonderful speakers and experts, and it's my duty now to ask Dr. Kumar to summarize the first 2 talks for all of you.
It was a wonderful talk by the 2 senior consultants, Dr. Neena Singh and Dr. Bhavna Banga, and it is very clear from the CME that when should we refer a patient to a gynecologist, and how should we counsel an infertile couple, and if there is an abnormal report in the male, then you should refer the patient to Dr. Bhavna for a successful outcome.
Very good. I must add that Dr. Gurmeet Bansal ma'am treated my own compounder. She would know it, and she has been married for 8 years, and ma'am counseled her. She had a tubal blockage, and removed the tubal blockage. She conceived and she has been successful. Thank you very much, Dr. Gurmeet. Thank you very much. I would now request my teacher, my idol, my icon, Dr. S.K. Sehgal sir, to summarize the pediatric part of the CME for us.
Excellent talks by Dr. Shahnaz and Dr. Pal. Dr. Pal was very exhaustive in her preterm care and all that. So, basic idea is to detect anomalies, to detect problems during pregnancy, and this is possible now by various screening tests and by ultrasound done early in life and subsequent tests also. And for preterms, it is very important, like the word she used was intrauterine transport, which means deliver the baby in a tertiary center rather than deliver the baby and then transport there. And of course, all the care that is required. She was elaborate and exhaustive about it. So thank you both of you for an excellent deliberation.
On behalf of Physician Forum of India, it's my duty on